Hello from Belgrade, Serbia. My name is Goran Stankovic. I'm an interventional cardiologist and I'm also board member of the European Bifurcation Club. First of all, I would like to thank the organizers of the meeting for the kind invitation to present Bifurcation Masterclass, case-based discussion, and I would like to share with you the latest data coming from the European Bifurcation Club meeting which took place in Madrid in October 2022. From the very beginning of bifurcation treatment with drug-eluting stents, we have several trials which compare single vessel versus upfront systematic two-stent strategy. And none of at least 11 randomized trials has shown the benefit associated with systematic two-stent strategies for bifurcation treatment. Nordic, BBC1, BBK, Cactus, etc. Even European Bifurcation Club 2 study, which randomized patients to provisional versus systematic culotte stenting in large true bifurcations with long disease in the side branch, did not show the benefit of culotte versus provisional stenting. However, longer-term follow-up even showed the worst clinical outcome associated with systematic dual stenting. Here you may see publication from Miles Behan, 5-year all-cause mortality from individual patient data from the Nordic and BBC1. And you see that during the first 2 years, there was no difference in mortality between 1 and 2 stent technique. However, longer-term follow-up showed divergence of curves with higher mortality with 2 stent strategy compared to single stent, forcing us to rethink whether systematic 2 stent strategy not only shows the benefit but worsens mortality at longer term follow-up. The latest data, 10-year all-cause mortality in the Syntaxis trial, showed very important 2 key messages. First one, the impact of bifurcation treatment with PCI versus surgery, PCI in blue, surgery in red, and clearly documented that in the Syntax trial, presence of at least 1 bifurcation treated with PCI resulted at a higher long-term mortality compared to no bifurcations. On the other side, 2 curves, bifurcations or no bifurcations treated with bypass, do not show the difference in mortality at follow-up. Second, what is very important is consistency with previous findings from Nordic and BBC1, because you may see also that 2 stents had higher trend for mortality at long-term follow-up compared to single stent. And if we perform landmark analysis until 5 years of follow-up and after 5 years, again similar to meta-analysis from Miles Behan, in the first 5 years of follow-up, there was no difference in mortality between 2 curves, although curves started separating with again p0.061 for 2 stents versus provisional. And after 5 years of follow-up, the difference in mortality between 1 and 2 stent techniques reached even statistical significance, with p-value 0.043, 23.1% mortality in patients treated with 2 stents, 14.5% in patients treated with single stent. For these reasons, European Bifurcation Club has the following ethos of treatment of bifurcation. We recommend to try to treat bifurcation simple and safe, limiting the number of stents. we also advise to respect the original fractal bifurcation anatomy and to try to reproduce this anatomy using tubular stent. Then we aim for well-opposed and well-expanded stents with limited overlap. And for those reasons, for us, provisional side branch stenting strategy is the standard approach for treatment of the vast majority of bifurcations, including the left main. It's important to understand that provisional stenting is a treatment philosophy and not a single stent technique. Provisional stenting for us is an approach to bifurcation treatment in a stepwise manner, adding layers of complexity as necessary, stop when you achieve the good result, and of course use two stents whenever it's necessary. The steps of this layered provisional stenting we describe in details in the latest consensus document from the EBC, the 16th consensus document part 1 that was published ahead of print at the time of Euro PCR 2022, and you can see central illustration in which we clarify, we define the steps of provisional, but we also discuss potential pitfalls and the troubleshooting, the way how to redo it. And we also describe the measures of preventions, how procedures should be done in order to prevent the occurrence of the pitfall. Here are the steps defined in this consensus document. Step number 1 is main vessel stenting, utilizing the stent according to distal main vessel diameter, jailing the wire in the side branch. And after implantation of this stent, we have to do pot. And we have to do pot proximal throughout the proximal edge of the stent. And then we evaluate the result. If the result is optimal, we can stop in majority of bifurcations after proximal optimization. Why it's important to understand fractal geometry? Look this 3D OCT animation. Coronary vessel does not taper linearly. Actually, at every bifurcation site, here is step down in diameter. This is the carina, this is the side branch, and you see how big proximal diameter suddenly decreases to distal main vessel diameter. It's important to see it also from inside. This is Visible Heart Lab initiative that we as European Bifurcation Club cooperate with Medtronic and University of Minnesota in Minneapolis, and you can see that after implantation in a pig heart we have discrepancy in diameters proximally and distally. In order to perform POT, it's critical to know maximum expansion capacity for each of the stents in our shelf. Very important, Medtronic currently has extra large vessel side with 10.5 crowns and 2.5 connectors, which can have maximum expansion up to 6 millimeters. This is angioscopy from inside after implantation of the stent. If we don't pot, you can see that we can go with the wire completely outside of the stent, behind the stent into the side branch, or outside and inside the stent. And on OCT reconstruction you can clearly see that there is no expansion throughout the proximal length of the stent. For that reason, what we do, you see stent floating, and we do pot with balloon sized according to proximal main vessel diameter, and we position distal marker exactly at the carina level. Why it's also important to understand that during this procedure we need to maintain our wire in the side branch jailed. So when we do pot, we don't pull out the wire. Why? Because jade wire may facilitate side branch reopening. And here is one of our cases: stenting of the left main towards the LAD, large circumflex codominant, and after stenting, complete occlusion of the circ. You can see here complete occlusion, and jailed wire can be used to open this circumflex, and I show you animation showing you how to do this side branch rescue. So this is stent implantation, and when you do pot, you don't do pot, you can go with the balloon behind the stent on the jailed wire. It's important before that to put pot balloon distally. After opening access into the side branch, you have to repeat pot in order to deploy stent and to perform complete stent expansion up to the proximal edge of the stent. After that, we use the third wire, rewire distally. After rewiring, go with balloon and do sequential kissing balloon inflation. And now you have to repeat pot throughout the length again, especially at the ostium of the left main. After removing the tissue, you see in this 3D fly-through that we are able to fully open access into the circumflex. And here is exactly what we did. We used the jailed wire balloon, we opened the circumflex, and then we did kissing, and we finished with excellent result without stenting the ostium of the circumflex. However, in case that after pot there is no optimal result in the side branch achieved, side branch is compromised or deserves further intervention, next step is to exchange the wires, either using the third wire or pulling back the wire from the main vessel. We have to also exchange the wires if we decide to do systematic kissing balloon inflation like in left main PCI. Very importantly, distal rewiring should be done pulling back the wire. We go with the wire distal inside the stent, and by pulling back we try to go in one of the distal cells. And here you can see, by pulling back we were able to position wire optimally in the distal cell. Next step after exchanging wire is to do kissing with or without repot, and after kissing we evaluate result again. If the result is optimal, we finish the procedure. Here is how kissing balloon inflation looks like in Visible Heart Lab. Two balloons, one in the side branch, one in the main, and after removing balloons, you can see that with kissing we fully open access into the side branch. Carina is nicely covered with metal, and we also push with metal some of the struts from the proximal main vessel, and we scaffold the ostium of the side branch. This is why with provisional and kissing we are able also with single stent to partially scaffold the roof of the side branch. Here is a clinical case example of provisional. For interventional cardiologists, angiography is our GPS. Based on angiography, and this is example of 62-year-old non-STEMI patient with critical distal left main ostial LAD subocclusion. So, according to angio guidance, we can understand the anatomy and the plaque distribution, and we try to estimate the risk of losing the circumflex in this case. Here is my interpretation. This is the contour of the lumen, left main, LAD, intermediate, and circ. This is the vessel contour. So all the plaque is actually opposite to the ostium of the circumflex, in front of the ostium of the LAD in distal left main and the LAD. So in my view, a risk of occluding the circumflex after stenting from the left main into LAD is very low, and for that reason provisional stenting crossover left main LAD will be my strategy with 3 wires. Here are the steps: 3 wires after stenting and tracing optimal final result is achieved. However, if after kissing result in the side branch is still suboptimal, then we go to stenting of the side branch. Step 5 is actually side branch stenting as part of provisional. When do we use 2 stents systematic? According to network meta-analysis by Di Gioia that was published in JACC Cardiovascular Interventions 2020, there are stratification according to side branch length more than 10 mm or less than 10 mm sub-analysis, which clearly shows that for short side branch regions less than 10 there is no benefit of systematic use of 2 stents. But in lesions with longer diffuse disease of the side branch, actually there is clear advantage of using 2 stent strategy. For those reasons and prior evidence, EBC states that elective 2 stent strategies may be considered for long side branch lesions, high risk of compromise or difficult access according to definition 2 study criteria. And we recommend to use provisional strategy with T, TAP or culotte stenting as part of the provisional. But we admit that there is enough evidence that for complex left main bifurcations, double kissing crush is also a good option. And this is the algorithm from the European Bifurcation Club, showing that in case of complex bifurcations, if the estimated risk of losing the side branch is low, then in that case we do classical provisional and we put second stent as T-stenting, TAP stenting or culotte. And here is a case example of diffuse disease with clear long lesion in the circumflex as well as in the LAD. How do we decide? We need experienced operator. Do we need balloon pump, rotablation, intracoronary imaging? The key is to have experienced operator, and strategy should be decided based on the EBC consensus. Again, this is the lumen contour, this is the plaque in the left main, similar to previous case. I think that if we go to algorithm, there is complex bifurcation with relatively low risk of occluding the circumflex. So main branch stenting and provisional ending with T or TAP stenting will be our strategy. And here is T stenting, first stent into the LAD, second stent into the ostium of the circ with final kissing balloon inflation. Next case, also complex distal left main disease, lumen contour, and then again we go to algorithm, low risk, provisional, and in this case decision is to do provisional culotte. And here are the OCT images, and provisional double kissing culotte is done. In this case baseline and final imaging shows good expansion by OCT in both branches, and double kissing culotte actually means provisional towards the LAD and then provisional towards the circumflex. In case that our expectation is that there is a major risk regarding the losing of the side branch or main branch, then there are 2 options. For experienced operator, option number 1 is to do decay crush, well-known 7-step procedure, and here is my animation to help you understand. So wire both branches, predilate both branches, and then stent side branch with minimal protrusion, optimization, and then sequential pot. After the sequential pot, proximal recrossing and the first kissing balloon inflation. After first kiss, stenting of the main vessel, pot, and then again proximal central recross and second kissing balloon inflation, and then the third final pot. And when we remove tissue, you see optimal expansion with minimal protrusion. Here is case example of our colleague, Dr. Shaolian Chen, diffuse disease in both branches. Clearly, a risk of losing the side branch is very high, and he selected, of course, double kiss crush. This is stenting of the circumflex with minimal protrusion. Then next step is to do sequential kiss, first with 3.5, then with 4.0. And the reason for sequential kiss, if you crush, sequential crush, if you crush with balloon sized according to distal main vessel diameter, because of the fractal geometry, you will have incomplete crush. This is visible heart lab that help us to understand we need to take second bigger balloon like pot and do second crush with bigger balloon in order to make procedure optimal. After the crush, we have proximal rewiring, first kiss, stenting of the LAD, then second pot, proximal rewiring, second kiss, and the final pot. And here is final angiographic result showing optimal expansion and confirmation by IVUS, polygon of confluence almost 15, distal left main 13 square millimeters, and pullback from the circ also showing optimal expansion of both stents. The other option, instead of DK crush, is to do inverted provisional, stenting from the main vessel into the side branch, then optimizing the result and putting second stent as inverted culotte, inverted elective T or TAP. And here is the case example, wide angle, very complex tight lesion 111, isolated left main bifurcation. We go to algorithm, high risk of losing the side branch, inverted provisional with TAP is selected. Why TAP? Because the risk of stenting first is very high if we stent first towards the LAD. Large calcium and plaque burden will create difficulties for stenting the second branch. For that reason, inverted strategy is selected, stenting first from the left main, you may see into the circ, and then positioning with TAP stenting, minimal protrusion at the ostium of the LAD, and the final optimal result. And the third case, again, very complex, distal 111 left main bifurcation lesion, patient randomized to EBC main in 2 stents. Which strategy to select? Again, similarly, inverted provisional, stenting first towards the circ, and then inverted culotte is selected. And here are the steps with animation, so stenting towards the circ. After stenting towards the circ, first pot with 4.5, rewiring towards the LAD and ballooning, and then second stent with mini culotte with minimal proximal overlap, and after stenting towards the LAD we do second pot. After second pot we rewire and we do second kiss, and then the third pot at the end. And here is the final result of the culotte stenting. And 1 year of follow-up, patient feels very well without angina and no shortness of breath. Finally, in addition to strategy decided based on plaque distribution, bifurcation angle, and plaque composition, I would like just with 2 slides to stress the importance of image guidance for complex bifurcation lesions, especially in the unprotected left main. Here are the data from British Cardiovascular Intervention Society, published again in JACC Interventions 2020, in which we can clearly see that image guidance for unprotected treatment resulted in significantly improved mortality. Hard endpoints were reduced, like in-hospital mortality, 30-day mortality, and 1-year mortality. And European Bifurcation Club strongly recommends use of imaging for complex left main PCI, and also complex left main procedures are recommended to be done either with IVUS or with OCT for distal left main bifurcation. Ostium can be better visualized with IVUS, so IVUS guidance for ostial left main stenting is recommended. And second, it's very important to know the role of physiology in bifurcation PCI, and we published together with Korean, Japanese and European bifurcation clubs this state-of-the-art review on the role of physiology in coronary artery bifurcation disease, and this is the algorithm showing you how to properly use also physiology, especially for the assessment of the jailed ostium of the side branch after main vessel stenting. And I strongly recommend this article for your attention. So, dear colleagues, I would like to conclude that stenting technique should depend on individual patient's anatomical characteristics and the operator's skill and experience. For us, European Bifurcation Club recommends stepwise provisional as logical, straightforward, reproducible and versatile technique, and remains the strategy of choice for the vast majority of coronary bifurcations. Elective two-stent strategies may be considered for important side branches with complex and extensive stenosis according to definition 2 study criteria, difficult side branch access or high risk of compromise. Using imaging and physiology is strongly recommended to decide stenting strategy and optimize PCI result. I thank you very much for your kind attention, and I like you to share with us all your questions and concerns. Thank you.